Number 1, cellular immunotherapy. CARs, or chimeric antigen receptors, are proteins that allow T cells to recognize a specific target on tumor cells. Specifically engineered CAR T cells are grown in the laboratory until they number in the billions. After the infusion into a patient, if all goes as planned, the T cells multiply in the patient's body and, with guidance from their engineered receptor, recognize and kill cancer cells that harbor the target on their surfaces. While the cellular immunotherapy field is early in its development, the response rate to many of these CAR T cell therapies has been unprecedented for leukemia and lymphoma patients who have stopped responding to all other cancer treatments. Going forward, cancer experts predict that CARs have the potential to become frontline cancer therapies by engineering the patient's own immune system to fight their cancer.
So to discuss the potential, the ultimate disruptive potential of engineered T cells, we have Dr. Marcela, recently recruited to MGH as our Director of Cancer Cellular Immunotherapies. And Marcela, the big challenge, as you know, is that you have the ultimate hope for a very small number of patients. So how do you democratize this kind of technology, both targeting solid tumors and potentially making an affordable, generally usable engineered T cell in 2 minutes or less?
Well, thank you, Daniel. So both of those, I think, are very important questions. So we've seen unprecedented results in certain small populations of patients with B-cell leukemias. But this is a complex technology. It's been developed in the academic setting over 15 to 20 years. And one of the big questions is, how will this be available to patients worldwide? And this is where we really have to thank our industry collaborators in being able to take this forward. They're really well equipped to figure out how to overcome the logistics and how to democratize this where it can be available to patients worldwide, commercialize it in one form. The other question that you ask is about solid tumors. So in some ways, because this is a complex therapy, we're lucky that it started in a fairly niche group of patients with orphan status disease, because it would be much harder to do this in a very common cancer with a very broader population. But I think that for moving this into solid tumor, there's 3 issues that need to be addressed, and this can be done both in the academic setting and with industry collaboration. And those are finding new targets for cancers, for solid tumors. 2 is being able to use different engineering strategies to be able to have T cells distinguish tumor from self-antigens. And then the 3rd is really addressing the tumor microenvironment. And I think we will probably use many of these other disruptive technologies that were described here, including epigenetics and CRISPR editing, for example, to be able to engineer T cells and to really be able to take this to the next level beyond just B-cell malignancies. I do think, though, that the first step is being able to do this in B-cell malignancies on a worldwide scale.
Thanks, Marcela. See, these are 12 amazing technologies, and on behalf of Monica and myself, I want to thank all our presenters for defending and presenting these technologies. You'll note that we gave ourselves 10 years. So these will be 12 technologies that will disrupt cancer care over the next 10 years. And in 2026, we invite you to come back to Boston and tell us how we did. Thanks very much.
Thank you.